2, 1. We are live.
Good evening to all. I, on behalf of Indian Society of Cornea and Cataract Refractive Surgeons, welcome you all in this webinar on advances in cataract surgery. We have a couple of wonderful speakers and a few very good panelists along with our ESCRS office bearers. And we have with us Professor Jayesh Tityal, who is the President of ESCRS and Chief and Professor of Ophthalmology in the Cataract, Cornea and Refractive Surgery at RP Center, AIMS. He has loads of publications and awards to his credit and various orations all over the country, being the first Indian to have performed the live cataract surgery at ACRS and has received the most coveted Padma Shri from Government of India by the President of India. Yes.
It's a pleasure to introduce Dr. Rishi Mohan, the Vice President of Indian Society for Cornea and Refractive Surgeons and also the founding member of the society, who is a RP Center alumnus and subsequently a very successful private practitioner. And he's held several positions as far as the administrative posts are concerned, which include the Joint Secretary of the Delhi Ophthalmological Society, Member Scientific AIOS, Secretary of the Indian Society of Cornea and Refractive Surgeons, Treasurer of the Eye Bank Association of India, Member Scientific Committee and Member Managing Committee of AIOS, Joint Secretary of Eye Bank Association of India, President of Delhi Ophthalmological Society, and like I said before, Vice President of the ESCRS currently. So welcome, Dr. Rishi. Always a pleasure to have you.
We have with us Professor Namrata Sharma, who is the Chairperson of Scientific Committee ESCRS and Professor of Ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center, AIMS, New Delhi. She is also the Regional Secretary of Asia Pacific Academy of Ophthalmology, Secretary of AIOS, Secretary Eye Bank Association of India, and has loads of publications and awards to her credit, various chapters, various textbooks to her credit, and has conducted numerous courses, both nationally and internationally, and truly an academic person. So we welcome Dr. Namrata in this webinar.
It's a pleasure and honor to welcome Dr. Himanshu Mehta, Director of the Vision Eye Center at Mumbai. Did his undergraduate and postgraduate training in ophthalmology from SAIT GS Medical College and KEM Hospital, Mumbai. Masters in surgery from in ophthalmology from Mumbai University, fellowship in vitreoretinal surgery from Dr. Charles Igrecia, Director Retina Services of Memorial Hermann Hospital in Houston, Texas. Has numerous presentations in international and national conferences. What is not mentioned here is that he is currently the president of Indian IRSI, that is the Indian Society for Intraocular Implant and Refractive Surgery. He's also the, to his credit, he has numerous programs which he conducts, which are, which we would term as, life beyond ophthalmology. And it is all about lifestyle and the way we should lead lives in general. And we welcome Dr. Himanshu Mehta, who's truly an ophthalmic surgeon of the celebrities, including the entire Bollywood. Welcome, Dr. Himanshu Mehta.
Thank you. Thank you, ma'am. Thank you so much.
We have with us Dr. Anjum Mazari, who is who's a senior consultant and head cornea, ocular surface and refractive surgery services at Indira Gandhi Eye Hospital and Research Center at Lucknow. His area of interests are excimer laser and phakic implants and cross-linking and corneal transplants. He has numerous achievements to his credit. He has been India's top 100 top MSME Award 2020 received. He also has the India Signature Brands Award in ophthalmology category 2020. He also has the Healthcare Excellence Award, Primetime Global Icon Award, Achievement Award from SightLife USA for highest number of corneal transplant surgery as an individual surgeon in the year 2015. He was the first surgeon to perform pure toric phakic IOL for astigmatism only. And apart from that, he is known for his large volume surgeries and quality surgeries that he keeps doing every now and then. So we welcome Dr. Anjum Mazari.
Thank you.
We don't have Dr. Raj Shekhar. He couldn't join, unfortunately, because of his some urgent family problem. He just could not join in the evening, he informed me. So we move on.
So we welcome Dr. Sharad Babu, Managing Director and Chief Surgeon at Sharad Max Vision Eye Hospital. Did his MBBS from Guntur Medical College, his post-graduation from Mangalore University, Karnataka. He is the treasurer of the Family Benefit Scheme and has played a very important role in the way the Family Benefit Scheme looks like in the existing platform, right from its inception. He's the past Rotary Governor, past President of Andhra Pradesh Ophthalmological Society, past ARC-AIO's South Zone member, and currently the Managing Committee member from Andhra Pradesh Ophthalmic Society in the All India Ophthalmological Society. So welcome, Dr. Sharad Babu.
We also have with us Dr. Sonu Goyal, who is the Director, Anand Eye Hospital at Jaipur. He is very good surgeon and very accomplished academician who is known nationally and internationally, specializes in complicated cataract surgeries and refractive surgeries. He's an excellent academician and a wonderful person. Has attended many national and international conferences as guest faculty, sharing his expertise, and has been involved in teaching. He is currently a member of scientific committee of AIOS and has been chairperson scientific committee of Rajasthan Ophthalmic Society earlier. So we welcome Dr. Sonu Goyal in this webinar.
It's a pleasure to welcome Dr. Suresh Pandey, whom I think I've known for over now more than 2 decades, right from his days in US. He is currently the person behind the Suvi Eye Institute Kota, along with Dr. Vidushi Sharma, his better half, graduate from Rani Durgavati University, Netaji Subhash Chandra Medical College, Jabalpur, postgraduate institute of, did his post-graduation from the PGI Chandigarh, fellowship at Storm Eye Institute, Medical University of South Carolina, Charleston, USA, and has numerous scientific papers in various international ophthalmological meetings, as well as authored several of these scientific papers and communication, along with 40 textbook chapters and 8 ophthalmic textbooks. So it's a pleasure to welcome you, Dr. Suresh Pandey.
We also have with us Dr. Rajiv Mukherjee, who will be joining shortly. He is the treasurer of ISCRIS and director and senior consultant, Mukherjee Eye Clinic, New Delhi. He is also a visiting professor at Feinberg School of Medicine, USA, and established cornea and phaco surgeon. He has presented many papers and courses at international and national level, and he is also the vice chairman of FBS AIOS, a very active person in both ISCRIS and FBS AIOS. So we welcome Dr. Rajiv Mukherjee in this webinar. And of course, I am Dr. Rajesh Sinha, working as Honorary Secretary ISCRIS and Professor in the Cornea Services at RP Center.
So it's a pleasure to welcome you, Rajesh, with numerous publications, excellent work that you're doing, both at ISCRIS as well as at FBS and at All India Ophthalmological Society.
Thank you, ma'am.
And across the country, the commonly.
Thank you, sir. So before we actually start the scientific program, I will request our president, Professor Tital sir, to say a few words.
Yeah, good evening, all of you. And first of all, let me welcome the experts on this particular field as a speaker and the panelists. I'm pretty sure we are going to have a terrific presentation and discussion. And the office bearers of our society is curious. Whatever we do in cataract is not enough. We know that cataract is the surgery for all of us. And every time we see somebody, listen to somebody, we always pick up some new tips to improve your surgical aspect. And that should reflect to an outcome for our patients. Whatever we do, it should ultimately reflect to the quality of surgery, should give a quality of vision to your patient. It's not only the surgery, it is the workup of our patient in a manner where we accurately calculate the intraocular lens power and plan the surgery as per the morphology of cataract, and execute your planning on the table. And we know that sometimes we do have difficulty. You may have to modify your surgical approach, may have to change your intraocular lenses on the table. But the ultimate goal is to benefit the patient and get the best outcome possible. And if possible, to improve the quality of life. I think the surgery of cataract is such which changes the quality of life of most of our patients. And I'm pretty sure today's presentation and discussion will be definitely beneficial to not only to audience who are attached to us, for us also. And thank you, Rajesh, for organizing the series of ISCARES webinars, along with Dr. Namrata, Dr. Rishi, and Rajiv, the important people behind all the scientific programs. I think we can start with the presentations.
Thank you, sir. Thank you for guiding us. And we begin the first talk with Dr. Himanshu Mehta, who will be talking about flax, whether it is just a marketing hype or it is worth its salt. And none other than Dr. Himanshu Mehta, who is so much experienced in flax. So let's listen what he has to say.
Thank you, Dr. Rajesh. Thanks very much for this. How much time do I have for the presentation? How much time to be?
10, 12, 14, 15.
Okay.
Whatever time you want.
Friends, as Dr. Tityal mentioned so very well, and I mean, the amount of affection and love I have for the rest of the team here. Every session, they are keenly listening to things. Dr. Tityal said such an important thing, that every presentation, every meeting we go, we get back knowing something, one extra word, and that changes our perspective somewhere, and that helps us deliver the best possible results to patients. I mean, the dedication that I can see with Dr. Tityal, Dr. Namrata, Rishi, Rajesh, unbelievable. They are there for every conference. They know everything. They might have gone through everything. They know more than me, but still they are there. And it's a wonderful thing to talk to them. I may be talking, it's not a monologue. Please stop me at any point of time. There is no financial interest. I wish there was. There isn't any financial interest. So what is the hype about flax? There's no hype. I'm not for it or against it. Let me present cases. I want the judgment. It's like Mark Antony with Julius Caesar. And so let there be peace and let there be knowing that what is the right thing to do. What are the reasons why we should be going ahead with technology? What is there for us? There was a time when we used to talk about those premium lenses and premium surgeries. Well, friends, for any patient, there is nothing called premium. Everybody wants safety, efficacy, reliability, repeatability, accuracy, precision, and consistency. As I tell others that a Sachin Tendulkar or a Virat or a Sehwag is allowed to fail 4 out of 10 times. And yet they are called the greatest cricketers and they can make millions of dollars on endorsement. Here, Dr. Tityal or Dr. Namrata or any surgeon listening to this, they are not allowed to fail even one particular time. Even a high court judgment can be overruled by the Supreme Court and the judges and the advocates have no problem at all. Here, we are daily scrutinized and there is an exam every single day for patient. What I'm trying to tell you here is that whatever that can make us give a comfort zone to the patient, wherein there is safety, efficacy, reliability, repeatability, accuracy, every step that we do, we have revised ourselves and why we are doing what we are doing. So if we have to show that when you have a patient who has an extremely shallow anterior chamber, you've seen 1.8 and 1.6 anterior chamber also. Forget 2.3, 3.1 is a great kind of a chamber that you'll have. You have a hypermetrope, 22.62, 21.71, 21.59, 20 point something, axial length of the eyeball, extremely shallow eye chambers. Now you can see here, if you can see on my left, a huge cataract almost touching the retina, pregnant cataract. If you see the angles, they are almost closed. You see the anterior chamber, there is hardly any place and there is tremendous positive pressure. So by the time if you take your incision, either the iris will walk out or your viscoelastic will walk out. Your rhexis may go haywire. You can see the cornea, which is bad. I will talk about the cornea also later. Anarchus, a bad endothelial problem. And they're all going to be there. And they have increased more following Corona, because they all waited. Earlier also, they never used to go for surgery till the last stage, and now 2 more years of waiting. So all these cases which are coming now are going to test your skills every which way. Look at that angle. Look at this angle. When you're going in on OCT, you can't see this routinely in life. But when you're doing an antechamber OCT, AS OCT, and or when you're doing your femtolaser, you will see on your strike that there is hardly any place for you to work. You want to be safe here because there is not much space to work. The cornea is bad. It's not going to be a great visibility that you'll have. So what is it that you can have? Irregular pupil. You have a trauma patient here. You don't know whether the zonules are broken in this case, whether the vitreous is coming in front for you or not. You rather be safe before you get into the eye. Something where, a great job is achieved once you have a great beginning. What I'm always, 80% of your job is a good first step in life. And this is where we need help from any kind of external source we can. So what is it that we can do? We have problems, and all these patients want results. They want results, and quite a few of them are one-eyed, compromised vision in the other eye, macular degeneration. All possible things that you can think of is existing with you. So we have something to our rescue. We can share and reduce our responsibility, because by the time you get in, if there is a pre-sliced nucleus and a lovely rhexis of a particular desired size, your life has become almost 70% normal. So the invisible and the invincible third hand of the femtosecond laser surgery is here to help you at that. And how? You can mark your incisions, you can take care of your LRIs, you can take care of the side ports as much depth as you want, depending on how bad is your pupil, how floppy is your iris. So your incisions can be earmarked well. Look at this cataract here, mid-dilated pupil. You can mark every possible thing. You can increase, decrease the size of your rhexis. You can mark your anterior capsule. It's a lot more, less stress on the surgeon when he gets into the eye than otherwise. Now that premium surgery, the so-called premium surgery with multifocal lenses, toric lenses, or any of these modified lenses that we have, whatever residual astigmatism about 1 diopters to 1.25 diopter, no cornea was born perfect. But when you're doing a multifocal in any given stage, your LRI is there to help you, because you don't want to spend double the money in toric multifocal. So here you have great help, because almost 60-70% of my femtolaser cataract surgeries, there is bound to be some amount of astigmatism which you can get corrected with. You have a small pupil, you have gone in, floppy iris, a shallow AC. By the time you start, you're fairly relaxed. You're not stressed out whether my rhexis will be okay. You have a pre-slice, you debulk the nucleus. Your chamber is now becoming a little more friendlier. You see how well the pre-chopped nucleus is there. It walks into you. It comes easily. You don't have to move your phaco probe. You don't have to do your chopper. You're blind actually. You're going underneath your capsular rhexis margin. Yeah, so I have to open like a parda and a veil. I have to open up and see where am I going? Am I okay? I can split and I can get off fairly well with those pre-chopped nuclei which are there. Makes life a lot more easier for me, for the iris and for the cornea. You have various patterns which are there for various kinds of surgery, from a soft cataract to a posterior polar cataract, and so the cylindrical pattern. We'll discuss that later. But here, as you can see, effortless brown cataract, preoperative parameters, one-eyed, corneal haze, low endothelial cell count, shallow anterior chamber. You can see the endothelial cell count which was there. But by the time I'm starting, as you can see, there is haziness of the cornea. You got a good rhexis, you're confident that you've gone there. The brown cataract, which is being effortlessly broken down, reduces your phaco energy. Whatever we say, whatever equipments we have, with Dr. Rajendra Prasad giving us a lovely chopper to go for the brown cataract, you have umpteen number of techniques described for a brown cataract. But only the surgeon who's there at that point in time knows how much his blood pressure is going to go up, because no two brown cataracts behave the same. Especially in a shallow anterior chamber and hypermetropes, you have very little space to work in with a floppy iris. And if it's one-eyed, with a low endothelial cell count. Here, you have a third hand which has helped you quite well. So universally, everybody agrees that when you had a flak surgery, the amount of phacoemulsification is, the energy used for phacoemulsification is less, whether it's torsional or it's a regular phaco, it's less. It reduces the postoperative corneal and endothelial cell loss. And in pre-existing patients with endothelial cell dysfunction, believe me, it's a great help. If your corneal opacity is going there in a bad, the femto will not work very well for you for a Lexis. But if you have a bad endothelial cell dysfunction there, you can still get away with getting a good parameter to reduce loss of endothelial cells. So what does a capsular dummy? Now that we are talking of premium, every patient wants to be doing everything effortlessly. They don't want to use glasses at any given point of time. It may be a monofocal, it may be a poor patient, rich patient. Everybody is going to demand glasses-free vision. The way we have told them over a period of time, no chashma, no injection, no putty, go back to work tomorrow. We have oversold ourselves and we are trying to live. So a Rexis of 4 millimeter in longer post-op and then the 6 millimeter Rexis. Then to ensure that the IOL position in the bag matches with the anticipated formulae. So you have to be clear with, as Dr. Tityal told us, right from the day the patient starts walking in and your preoperative preparation, everything goes into giving the best results to the patient. The whole experience, the whole understanding, every single day we are getting more and more understanding, newer formulae coming up, newer understanding of the subject. ELP we weren't talking about the posterior cornea. But as all these things matter and as we are getting more and more closer to achieving excellent results visual, as you can see that ELP, if a lens is 0.5 millimeters posterior to the assumed plane, a 21 diopter lens will produce a 20 diopter of correction, and vice versa if the lens is in front. Now you can see you have a subluxated lens. You may have vitreous in front of the lens here. On the right side, as you can see, the lens is tilted down. There's a traumatic injury. And if you have this kind of a lens, by the time you have got into the eye, you have a pre-chopped nucleus with a good Rexis. Believe you me, it saves a lot of trouble. You can put your capsule hooks, you can salvage the lens, which will help you to act like your external support. Your Rexis margins can be pushed up. It can help you phenomenally without disturbing the anterior chamber or the vitreous architecture. And instead of the lens sinking, because it's in the same proportions as it was dynamically. So if you can see here, as I'm marking, I can get my marking going on the anterior capsule. I can decide how thick is the cataract and how well we can break it even before we start the surgery. You can plan your incision also in an area which is not having vitreous. You can plan your endocapsular ring in a way that you'll be able to put it that way. So your incision would change. Your understanding of the whole dynamics of the eye would change because you could do that. So the subluxated crystalline lens, which was there. Now, if you have a posterior polar cataract, come what may, whatever we may say, whatever techniques that are described, there's always a new technique coming up. We have learned a lot more now. Visco dissection, we can do a good Rexis, we can do many things otherwise also. But a good cylindrical dissection with a decent Rexis gives you a definite upper edge to start with. Because every posterior polar cataract, even now I have to tell them that I might have to do it in 2 stages. You might have drop pieces. You may be unfortunate enough to have a small amount of piece dropping by. You have no choice but to tell them. But if you have this much ready, even before you have got into the eye, it is a great amount of relief. Your pulse blood pressure. And friends, you know, your anesthetist is always measuring the pulse blood pressure of the patient, but nobody is measuring the pulse blood pressure of the surgeon whenever they are going through these complicated surgeries. And all the people watching here are only used to complicated surgeries. Every single day, there are more and more challenging cases. So no Holter monitor is applied to the surgeon. But here you have some chance that it can reduce your problems. You have a hypermature cataract, you've done your readings, you can go ahead straight ahead. And when you are there, your laser emission starts, your Rexis has been perfected. You are sure that you don't have an Argentinian sign. You don't have to worry about it. It helps a lot in these patients to start with, because rest all is not going to be very difficult. The moment all those techniques for describing the entry into the anterior chamber and entry into the lens, there you go. You have a good rexis defined and you have the lens being split up. It's a lot more easier on you to get on with it. Here is a traumatic cataract, iris tear, dialysis. You can see, I was not even sure whether the lens has broken up and the fragments of the capsule are there outside. But yes, as you can see, I went in, fair touch wood, no Argentinian sign. You could get an Argentinian sign even after doing a femto, but less chances because it's a closed chamber. It's breaking up the capsule. It's breaking up the nucleus. I'm fairly more relaxed now when I get in. I know I'll be able to handle the subluxated part if it is there. My hooks will be there ready. So you have mental peace when you're doing such cases. And this is one of the loveliest cases that, a one-eyed patient, dirty arcus, extremely dirty cornea. You can see the angle, the anterior chamber, which is like hardly existing. Where in the world will my needle or forceps go to make a rexis? The pupil is small. You have everything going against you. And yes, one-eyed patient, believe you me, this is a patient which is absolutely challenging. You're playing God here. And the stress is on you. But if you have this, you can see on the right side how big the cataract is. Once again, touching almost the retina. And the cortex, which has got cortical adhesions with capsular cortical adhesions with calcification. Look at the angle on the right side, closed. So here again, if I have been able to get into the eye and see that things are a little easier. There, I have a pre-chopped nucleus. I'm fairly okay. I can go ahead and put in a Malukin later if the pupil is going down on me. But on the right side, you wonder how huge is the cataract and how bad is the posterior subcapsular area. So, as I said, Mark Antony and Julius Caesar, is it a hype? I'm not going to say anything. There's a lot more to be studied, a lot more to be done. But every cataract, every battle, every day that we face, we have to win. And every single case is such an opportunity and a problem by itself. We have to take on head on what can be done with. So if we have improved refractive, because no longer cataract surgery is cataract, is refractive surgery, uniform shape, predictability, corneal astigmatism, and early wow factor. Everybody wants to see their WhatsApp by evening. If they don't, then you're not a great surgeon anymore. So how to achieve? Well, achieving effective lens positioning, ELP, better control on incision architecture, reducing the phaco energy, effective management of the corneal astigmatism, safe, reproducible, predictable results for the patients. So this is what, without much time, that I would say that this is where I found that when you are talking of premium surgeries, of course, little choice, you have to be good in every possible aspect to deliver the best to the patient, to put the lens in the right place. But also in a bad cornea, in one-eyed patients, in problematic patients, it is a great support to us and no negative surprises. It works fairly well. I leave it to the audience. Thank you very much for giving me this time and opportunity, Dr. Rajesh.
Thank you, sir. It was a wonderful talk and the message was loud and clear that yes, it is a wonderful tool that helps us to improve the outcome of the surgery, and particularly in difficult scenarios wherein, total manual surgery can have some surprises. So before we actually go to the discussion, would like to have the comment for the panelists of this talk that Dr. Anjum Mazari would like to have your opinion.
I agree that it simplifies the many automated steps of cataract surgery. But seeing the long time result, now many researchers published the papers and coming that all the safety and efficacy are comparable to MICS. So just for even the rexis part, initially it was claimed that rexis is very good in this case. The electron microscopic study was found that the conventional CCC is better than the age is better than this femto cataract surgery. So just for these few things, it is fair to invest so much and load the patient such amount of money. So I just want to Mehta to comment on this, please.
Anju, great pleasure seeing you after a long time, Anju. The only string attached to the whole thing is money, 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 and money. If it is not money, every possible case you will do this. So let's put money on one side. I tell you,
But
when I
you
got this
see,
machine,
one thing more, you will see the more complicated cataract in the poor patient only, because those people are rich and go early cataract surgery.
So if you, Anjum, that's what I'm saying, those, if you put money on one side, if you are in a communistic country, if you are somewhere else, government is paying for it. Would you like to reduce your blood pressure? Would you like you to live longer, give more family time? Your own thing, your results for the patient, your consistency. I'm trying to say we are attaching everything to money. If we cut off money factor, I promise you, I've asked in multiple talks, I would say every surgeon whom I would be operating, I'll do it free, but I'll do it with a femto. If it is your eye, period. Any parent, any doctor.
Yeah.
So it's the only cost, the thing we tried comparing, and we always keep saying that the results are the same. This is that. I don't deny we were great surgeons. I mean, I'm not a great surgeon as you guys are. But if I can get results, I'm just trying to get some support to see that we can get it best.
That's why it is good in the very selective cases, but the third one country like us, we can't give such kind of offer to every patient.
I guess finally it comes down to the same thing, and maybe with time, if the cost of PI, the cost of other things come down, then it may become even cost effective. And one thing is definitely sure, that in difficult scenarios wherein the outcome is a bit more unpredictable when you're doing complete manual, those cases definitely femto has an edge in terms of clinical outcome. Is definitely there,
because it does basically all the most critical steps in automated manner, so it's good for the.
True. I'll request Professor Tityal sir, who has loads of experience in femtocataract surgery, to give his comments on this.
Rajesh, Himanshu did a wonderful presentation, covered every aspects of cataract surgery. Because I take it femtosecond as a part of cataract surgery only. In fact, I had modified the term flex to flaps. That is a femtosecond assisted phacoemulsification surgery. It's not going to assist other modes of surgery, but it's a beautiful assistant of phaco surgery as such. And as you rightly pointed out by Dr. Anjum also, if you have a machine with you, then maybe every case should be taken up in the femtosecond mode if the situation permits. Sometimes the machines are difficult to manage. They are in a different area of your main operation theater, and that's also difficult. But I'm pretty sure in future we'll have a machine which can be drafted or shifted into your main OR without any maintenance required for those cases. And the other area, apart from the challenging cases, the other area which I'm looking forward is the use in pediatric cases, which is going to be acceptable in those scenarios where the machine can be pushed into your GAOTs. That is one area of interesting for a future also. But yes, it does have an advantage in a difficult cases, but it has an advantage in normal cases also. As Himanshu rightly pointed out, we do have to consider surgeon, we have to consider patient, we have to consider the your entire operation theater management, right from the financials onwards. But yes, I'm pretty sure future is going to be some sort of assistant with laser. So it will be modified, but pretty sure the newer generation will all be doing surgery in the femtosecond assisted devices in future. If I go back to our time, just 30 years back or 35 years back, we were doing non-microscopic surgeries, and everybody said, what is this microscopic and extracapsular surgery as onto your heart problems, it's so much difficulties. But ultimately we boil down to a newer microscope, newer machines. Surgery cost has increased, but apart from that, it is a one-time surgery for most of our patients, and they would go for if given an option. And the government, I'm pretty sure today, the PMJ or the insurance cover is maybe 7,500 rupees for cataract surgery. I'm pretty sure this will increase in future because demand will be there from the general public also to have a better surgical assistance. If not the surgeon, the instruments and the machine has to be better. So I'm sure that is a future way of looking. And as the newer generations are getting trained into these devices, they'll acquire these devices and they'll formulate the prices also in a manner. More the use of machines, more is the requirement of machine from the users, the prices will come down. And it is today is the major block is there are few machines are running. Once you have thousands of machines running, the cost will come down 100 times than what it is today. So it is our duty to make our younger generation expert into these devices so that they go into this thing. Today, if somebody comes out from RP center generation, they are not going to buy a system which is not going to give them advantage. They'll go for the best possible. So that is what we have given our students. And I'm pretty sure the future is going to be better for all of us to give a patient something, as Himanshu rightly said, they would be able to do things immediately after surgery. And that is what we are looking for. So I'll go for a femtosecond always, though the price is definitely a problem, but it can be managed. Today, if patient wants a trifocal lens, which is going to cost a significant amount, they can afford this device also. It's a one-time investment.
Right.
I want to ask one question from all the people who are doing femto and conventional both. In your hands, you are such great experts. In your hands, will the clinical outcomes differ whether you do flax or whether you do conventional phaco?
No. If you look into ultimate outcome in terms of only the vision or a visual acuity,
quality of vision, sir. Okay.
It may not make a huge difference. But if you look into all the aspects, it has a physical aspect, it has a psychological aspect, it has the the difficult case scenario. One important thing for patient is patient comes with the idea of a femtosecond laser surgery. You say no, the patient will immediately be put off. You say, I have come for a femtosecond assisted surgery. You're saying no. As soon as I say yes, I can do it, there's a positive response for patient. And I know that I have given this example earlier also a few years back. A person like Namrata goes to one store and buys a sari worth which is a 2 lakh rupees sari, and another person goes to another area, gets same sari in 20,000 rupees. It's same looking, but the psychology of that person is different. I've got a sari which is 2 lakh rupees, but the appearance is same. The quality of vision will be all right, but the emotional and psychological thing will be much better with the surgeon as well as for a patient also. That is another way. But given an option, I think the advantage is definitely there. Few things which Himanshu highlighted: the effective lens position, better centration of your axis, better adaptation to those cases where you have endothelial compromised situations, and cases where you could do many steps without opening the eye, like a subluxated cataract, posterior polar cataract, post-vitrectomized eyes. This has a huge advantage compared to manual surgeries. Today, if I operate somebody who has these, like a typical posterior polar cataract or subluxated, I might opt for a femtosecond, despite knowing that I can do a manual surgery also. But there are patients, I operate a very old patient also, they have a cardiac problem, they have so many other problems. Twice putting them in operation theater may be a problem sometimes. I may not have a good cardiac monitoring in the femtosecond area. So these patients, I might do a simple surgery so that I can take away these patients out of OT within 10 minutes. While femtosecond device will increase the time to almost 20-30 minutes. That is also important considerations.
Just to add one more point, sir, here answering question of Dr. Namrata that, what one should do. I think a procedure is considered very good when it is reproducible in the hands of everyone and reproducible in every case. And with the assistance of femtosecond, as sir was telling, Dr. Tyal sir was telling, with the assistance of femtosecond laser, it can be reproducible, the same result reproducible in case after case, and even in hands of any surgeon. So that way it has an edge, and if no additional cost to it, In that case, then the question arises whether you would like to do femto in all or you would not like to do femto. That is one issue. So if there's no cost to it or no additional cost to it, then maybe people would like to go for femto in every case.
Just one more point, Himanshu, before you say, there is a definite learning curve in this surgery also. Sometimes you have to undo your, the way you do a routine surgery in a femtosecond, especially opening the incisions. Your incision may be a little difficultly oriented than a normal cases. Your axis may get little changed. The rhexis management or capsulotomy management will be little difficult. But most importantly, because you have done some sort of fragmentation or softening of nucleus. Your nucleus management is totally different than a routine phaco surgery. That people have to understand. Like your power modulation, your parameter has to be modified as per the femtosecond softening of nucleus. That is the only one area I always tell the younger people to think before you do a routine nucleotomy as you do in a routine case. That's a little challenging with some patients. I've seen people going through and through, right to the first phaco and they are into the posterior capsule. So that area, little learning curve is there in these cases.
But Himanshu wants to say, yes.
I'll just quickly wind up. Anjum, when phaco started, everybody was talking about money. Everybody talked about money, and we don't even talk about money anymore now with phaco machine. End of the day. With LASIK, it was microkeratome. We started with the femto to make a flap. Two separate machines and the cost we have borne. Second most easiest example I give. This is the thing which will be thrown off in 1 or 2 years. This is dead investment. This is not investment. This is gone. Correct? Whereas this once in a lifetime, less cost than this. And yet we talk about this, and every citizen of this country has got this now. Geo is surviving on this. The block is more in my head that the patient can't afford. And with the money coming in and the amount of money that we have in this country, with 300 million in the FMCG, I was shocked. 200,000 iPhones were ordered on that Flipkart sale day. Can you believe that? This is official news, and we are worried about money. It's there. It's just there. We have more block. That's all that I wanted to share.
Any other comment from any other panelists?
So, Dr. Rajesh, can I make a quick comment? Doctor, I want to ask Dr. Tityal and Dr. Himanshu, is there any increased incidence of PCO or antichamber reaction after flex as suggested by few earlier studies? What is your experience about doing flex in the difficult cases such as small, like, a cell antechamber, as you have nicely shown in the first case? So is there any increased reaction, antechamber reaction when you see these cases on day first op? And what is the long-term effect of flex compared to phaco in terms of PCO?
Sir, I haven't seen any reaction for sure because of the flex. Not a single case that I would say. For sure, whatever number I've seen in the last 6 years that I've used it. Okay. PCO, it all depends how well I've polished and I've removed the anterior capsule, the underneath of the ND capsule. Rate similar kind of. But the PCO rate, more YAG would be done if I have used more multifocal because they need to have more vision. That's about all.
I think it's the same with me also. And yes, they were initial when we started doing all these devices. They were concerned that antechamber reaction will be much more in these cases, especially with the release of inflammatory cytokines when you use a laser in these cases. But studies which you have also done looking into antechamber, we have taken a AC aqueous for these patients after femtosecond and tested all the inflammatory markers. They were definitely increased than a normal routine cases where we don't do femtosecond. But looking at the post-op assessment of these patients, we looked into 2 areas. One was antechamber cell flare in these cases, day 1 at 1 month and 3 months, and the central macular thickness. There are 2 areas we checked after a femtosecond compared to the manual surgeries. And there was no difference at all in these groups. Maybe our selection of cases were normal cases, but your question is on difficult cases like a small pupil. But there has been some cases where the pupil did constrict very significantly because we did not manage the capsulotomy area as per the pupil diameter. You have to have some area remaining there, if not 0.5 millimeter in these cases. And some cases, because what I used to do earlier, I should do a femtosecond for 2-3 patients at a go, because I had to do myself. Then take one by one for surgery. By the time I came to third patient, the pupil would have constricted because of inflammation which comes up after laser application. So those cases, even there also, the surgery was a little difficult, but we could manage those also. There was no significant increase. But there are some cases where we don't do a proper, as we do for a aggressive hydro procedure in a routine cases. Here we do a more of a femtodelineation and less hydro required in these cases. You may have some capsule may not look as clean as your routine cases. But yes, as Himanshu rightly pointed out, if you do a good polishing of posterior capsule, they should behave like a same group of cases. So I did see initial cases where I never did a good polishing because we are worried to finish the cases as effectively. You did have a little hazy posterior capsule in some of the cases, because if I remember correctly, one publication by Dr. Abhay Vasavada long time back in JCRS, he reported, I don't know how, if actually boils down to, he said if you rotate the nucleus after hydrodissection more than 3 times, your PCO is less. That was his publication way back. So it does have a meaning. You do a good rotation, the fibers will get detached from the attachment of the posterior capsule, the cortical fibers. But it boils down to the good polishing of a posterior capsule.
Any role of topical NSAIDs in these cases?
Yeah. Rajesh rightly pointed out. We do for every case. In fact, I started using all these, acular drops for a patient with a femtosecond to begin with. But nowadays we do routinely for other cases also. We did start acular drops at least 2 days before the surgery for these patients, and it does decrease the pupillary constriction in these cases.
Okay, so we have been talking about difficult cases, and our next speaker, who has a couple of cases posted now after his talk, would like to speak on a difficult scenario, and that is subluxated cataract. So we will have Dr. Sonu Goel will be talking on subluxated cataract.
Also, I'd like to thank Professor Dr. Tyal sir, Dr. Namrata Sharma ma'am, Dr. Rishi, and my dear.
Are we going to see a live surgery or what?
Rajesh, I'll take you through a virtual tour, sir.
Okay, good. Yeah.
And
welcome.
So it's a wonderful session, and it was a wonderful talk hearing Dr. Himanshu. And so Dr. Tyal sir made me shift one of my slides, and very rightly sir said, subluxation management is altogether a difficult ballgame. And whenever we are entering the OR and whenever we are planning these patients, we really need to look into the armamentarium that we have. Dr. Rajesh, is my sound and my video clear and audible?
Yeah, absolutely. Absolutely loud and clear.
So the choice of capsular support. So these are the arms that I would always have whenever I'm looking into one of these patients in my OT. My preoperative workup has already been done. I've analyzed the extent of zonular lysis, whether it's a progressive or a static, and what is the strength of the zonules. Because this gives me a fair idea as to how to respond now and what kind of supports I would be requiring. So a capsular tension ring, or maybe a Sioni CTR, an Ahmed segment, an AC anchor device, a hook, or a capsular hook. So dividing into the clock hours of zonular lysis, so less than 3 to 4 clock hours, I would prefer doing just a capsular tension ring. Somewhere between 4 to 8 clock hours, I would do a single support. So maybe a Sioni CTR or a CTS, a capsular tension segment with a capsular tension ring. A CTS plus CTR would help me for a single point fixation. So dealing with more than 8 clock hours, I would prefer doing CTR with 2 CTS. And the SC anchor device is a wonderful device that I've been showing in all these difficult scenarios. A quick word of the material that we have been discussing to provide support. Yes, we all have been using the 9O or the 10O polypropylene, but over these years of our practice of over 2 decades, what we have seen that this hydrolyzes over a period of 5 to 10 years. So now I have shifted to what is called as the CV8, that is the polytetrafluoroethylene, and the lasso technique works equally well with all these patients. So a series of patients that we have operated. I think this is one of the lenses we all would remember putting these 10 to 15 years back. I think this was Pharmacia, the silicone lenses. They were a sort of, these were foldable lenses. Slightly, when they were unfolding, they came up with a jerk. And these were the lenses that we have been used to. So one such patient came to us a few days back, and you see the lens is subluxated, maybe some trauma. The bag is disrupted, and this is a silicone 6mm lens inside. So the only way which I could address was to remove and reimplant, but reimplant using maybe the Yamane or the glute. So I thought on a different ball game. So 180 degrees apart, 2 Hoffman pockets. So the marking is essential because you always have to be 180. So I make a side port entry, and this is the 8O Gore-Tex that goes in. And what I'm trying to do is, the plan is simple, to suture the 2 haptics within the anterior chamber. And look, I just have a 1.1mm incision here. So I proceed. This is one suture. I dial 180 degrees, push in the second Gore-Tex underneath, try to manipulate it under the haptic and suture it. And yes, here I am ready with the IUL to be fixed. Now the wonderful technique of lasso comes into play. This is a 26 gauge needle where I have reversed, entangled the 8O, and this acts as a lasso. So this is a loop which I have created, and within this one of the loop, I have tried to externalize the suture. The second goes through and then externalized. The loop is created, the suture is passed, and look, now I have externalized both the sutures, and similarly goes from the opposite side. Sutures are trimmed, cut, and they are pushed inside the Hoffman pocket. Triamcinolone staining, a quick vitrectomy, anterior, and this is how the day one picture looks like. So no trail signs of any incisions of in the cornea. The bag is stable, and you have a perfectly placed the same lens within the eye. Yet another case of a Sublux cataract. So if you see here, 2 side ports. I always stain with triamcinolone. Any vitreous in the anterior chamber is taken care. Now rhexis is very important. A centered rhexis here, and very rightly, I think the role of femtosecond laser, as Dr. Tetial sir pointed out and Dr. Himanshu Mehta said, it's a closed chamber. So we don't want the vitreous to move out. So in a closed chamber, if we can achieve a rhexis with a femto, nothing like it. So the capsular hooks come to the rescue. A quick phaco aspiration because it's a soft lens, and the bag is distended. A CTR goes in. I position the capsular hooks now almost 90 degrees apart. Quick aspiration of the lens matter. And here the choice of lens would be a 3-piece. I create a Hoffman pocket again. This is the Emmett segment, and this is how you create a loop in the Yamane technique. This is the 8O Gore-Tex, which is threaded into the Emmett segment. The segment is pushed inside the bag. And very carefully note, this is the lasso loop. I withdraw this loop, and this would then be threaded with one of the ends of the anchor device. So the MH segment has to be externalized. The two ends of the Gore-Tex, the second loop, threaded again and externalized. This goes inside the bag. Very carefully, it is nudged and the sutures are withdrawn. And I withdraw these sutures from the Hoffman pocket which I have created. The suture is then trimmed, and then I would inflate the bag, push in a 3-piece here, just in case if anything happens, I would be able to convert into a Yamane or a glued IO. So it's well centered. And what I now look is into the 3 Purkinje images and centralize the lens back complex. Look carefully, the suture is being titrated and then can be trimmed and it can be nudged inside the Hoffman pocket. So no chances of exposure, a stable lens back complex, and you're pretty sure it's going to stay for years within the eye. So this is yet another way to manage these cataractous lenses. And this is how the day one picture would look like. A stable lens back complex is all what can be achieved. So this is, you can see how it's dangling freely. And here is the lens. Now, what is more important in these patients, there is vitreous, there has to be triamcinolone staining, and you have to have a centralized rexis in these patients. So these are not amenable actually to femto platform. So what is important is that you have to create an initial opening like this, and then you have to pull the bag. It's an elastic capsule, and then you have to achieve a rexis which is almost circular. The aspiration is quite easy here. Reposition the capsular hooks. The bag is distended using a capsular tension ring, and this is the ASI anchor device. I would just like to show this device here. Oh, I'm sorry. So this is the ASI anchor device. It's a beautiful clip-like of device. I create again a Hoffman pocket, the same lasso technique, and the two ends of the ASI anchor device has been threaded. Just need to be externalized, and watch very carefully how beautifully, like a paper clip, this device centralizes the lens back complex. See, now I'm trying to stretch and the whole lens back complex is centralized. The suture can be buried within the Hoffman pocket, and you have a decent centralized lens back complex. The lens here is a single piece, and this is the day one picture of these patients. So no iris trauma, no incisions, no sutures, no glue, and that is what can be achieved. Now, this is one of the, okay, this is one of the patients which really made me slog and put my adrenaline. Just watch carefully. I made multiple side ports, portion viscoelastic so that the vitreous is not coming. I try to make a rhexis. Same, I'm trying to support with the capsular hooks, trying to fashion a round rhexis, which I've achieved. I make a main port and watch slowly. I'm trying to push the ring, but unfortunately there is some force and I'm not able to pass. So I just withdraw, do a careful hydro dissection, do an irrigation aspiration. The lens is soft. So now I try again to push in the ring, but somehow the ring doesn't go in and I've created a break. Still, I was a little daring. I just thought if I'll be able to support the bag and push in a 3-piece lens inside, I would then be able to support. So I push in a 3-piece and I'm pretty sure I would not deliver it directly inside the bag. I go and just watch carefully. The moment I withdraw the capsular hooks, just watch here. The hurricane goes like this and there is a rip and the PC goes off. So something has to be done, either a Yamane or the glue. But suddenly the thought of the 4th row pupilloplasty getting converted into a 4th row supporting. So I am doing a posterior enclavation of the haptics here. So I pass this 9-o-proline and do a 4th row, and here I'm able to achieve a stable. So again, boiling to the same situation, that we should all be prepared with all the arms and all the ammunitions that we have in our OT for managing these situations. Rajesh, you can stop me anywhere. I think this is the last video that I'll be showing. So this is a patient with aniridia, again a freely dangling lens, but just wanted to have a single support, and unfortunately my OT staff says, sir, the Gore-Tex is not available and we neither have the 9-o-proline. So I remember Sri saying of his wonderful technique of using a 6-o suture here. So just watch. I have been able to create a rhexis, a very gentle phaco aspiration. It's a soft stuff. So I'm just able to aspirate. Distend the bag, push in a CTR here, and now I push in a single piece within the bag. And now this is the 26 gauge and I pass the 6-0. I externalize this, pass in to the MH segment, make a small stump for tries, push in inside the bag, and through the pocket that we have, just trim, centralize the lens bag complex, and that's the emergency rescue that we were able to do it. And in the second stage, we could manage the aniridia as well, a stable lens bag complex that we were able to achieve. So subluxation, though, might be difficult, and this is the post-op picture where you can see a very centralized lens bag complex in this aniridia patient. And we were able to deal nicely with these patients. So I would like to thank, I have ample of these, but time, respect.
Thank you, Dr. Sonu. It was, a good collection of some very difficult cases which you showed. Would like to, Dr. Suresh Pandey, the panelist for this talk, would like to have his comments on this.
Thank you. Dr. Sonu Goel has shown excellent videos of managing these tough situations of subluxated cataract. And by showing the video, very elegant technique he has shared with us, Thank you, Dr. Sonu, for sharing excellent videos and difficult case scenario. As rightly pointed out by Dr. Sonu, that we have tools and technology to manage such difficult cases. It's very important to do a pre-operative thorough workup of these cases and to evaluate the area of journal adhesions to see whether there is a presence of vitreous or not in the anterior chamber, and thorough slit lamp examination, posterior segment examination is very important in such challenging cases, and one should counsel these cases for the taking the long surgical time, and for the need of periodical follow-up, and need for the retinal examination, need for the resurgery. So that's why the counseling is very important in such cases as well, and one should always under promise and over deliver, because sometimes these cases can come, or cataract surgery is 10 minutes job. So as an ophthalmologist, we should be very careful to explain the risk and explain the possible complication which can happen in such cases, and the need for the resurgery and the need for the follow-up should be emphasized for each and every case. And it's very important that nowadays we have various tools available with us. We have CTR, CTS, the ASIA anchor. And my question to Dr. Sonu is that did you try the glued hemicapsular ring invented by Dr. Sujan Jacob? Have you experience of using those hemicapsular ring?
I think, yes, the technique that Susan has developed, I think that's also amazing. But I think you would all agree, I think whatever works best in your hands, I think that's the best way to go. So I think we've done a lot of glued IOLs, we've done Yamane also, and n number of different things. But I think at the end of the day, what is more important is the best that works in your hands and is you're able to deliver the best to the patients.
That's very true, Dr. Sonu.
Dr. Susan's technique again is wonderful, and Priya is also working on that. And I think that is also an amazing way to handle these malposition.
Yes, very true, Dr. Sonu. And I think very important thing that most of the ophthalmologists are now working to preserve the capsular bag, to preserve the lens which is implanted. So more and more techniques are coming up, which are showing us how to retain the capsular bag, how to use the same IOLs as Dr. Sonu has shown in his first case. So, Dr. Sonu, I want to ask you one quick question, that in Marfan syndrome, where you have shown the journal adhesions. So, compared to the technique which you have used, the CTS and the ASIA ring, how do you compare your experience with the glued IOL versus preserving the capsular bag?
I think natural physiology is what we are aiming at, and preserving the capsular bag and placing these lenses within the capsular bag is what you aim at, and without creating any disturbance in the vitreous. Anyhow, whenever you're doing a glued IOL or whenever you are doing a lensectomy along with an anterior vitrectomy, you're always trying to disturb the vitreous space. And as we have seen, that once we have created a barrier, that barrier still remains, and that is what the essence of putting a CTR and a CTS and doing all these cases is just to maintain that normal physiology as far as possible. So maybe either by using a single support or a two support devices, the basic aim has been, even for freely dangling lenses. I mean, we've done a number of cases where it is a 360-degree kind of freely floating lens within the anterior vitreous. So we have also addressed these patients, and they work amazing.
That's very true. And I would like to ask Dr. Tiyal sir, Dr. Himanshu Mehta, Dr. Rishi Sarup, that what is their experience of using the glued IOL versus the preserving the capsular bag?
I think Dr. Suresh, there are no
Rajesh can answer,
Yeah, Rajesh can answer that because he's doing both. And there are no studies which have, compared glued IOL versus preservation of capsular bag with the capsular tension rings and the hooks, etc. So I think ring and the segments, etc.
Yes,
so till the time you have that, it is very difficult to say.
Yeah, it's very difficult to say. Most importantly, what you want is that long-term stable IOL. That is the key. Well-centered IOL. That is the key. And whatever way you can do it, it is good. What we have noticed, one thing is that in cases of congenital subluxation, wherein the subluxation is there because of congenital causes, therein the subluxation is progressive. So even if you put a Sionis ring or some, what happens that with time the capsule contracts, and we have seen a few cases after 10-15 years of follow-up when the capsule has contracted and the whole bag and the IOL has got a little decentered. So in traumatic subluxation, etc., definitely my preference will be to preserve the bag, to keep the capsular bag, fix it up and all that. In progressive subluxation, I prefer doing a glued IOL in these cases, because we have noted some of these cases coming to us with the whole Sionis, suture, etc., everything like this on one side because of the contracture that is created by the capsular bag fibrosis. Now, it doesn't happen over a period of 2 years or 4 years or 5 years. It happens after 10, 12, 15 years time. So that is what we noted. So that's what I practice normally. But yes, as Dr. Namta told that there's no comparative study. I guess it will be difficult to say. Personal preferences and personal experiences do matter in these.
I think very rightly pointed out by Rajesh that in these patients, if the rexis size is small, at times you find that the bag again after a few years, gets off-center. So I think proper fixation, proper sizing of rexis, and proper clearing of the lens matter is again very important when you handle these patients.
So
I have noted in this. Yes, sir.
No, sorry. Go ahead, Rajesh.
Yeah. One more thing I have noted in these cases is that when your bag, the posterior capsule is absolutely taut, then in that case, the capsular fibrosis is not seen. But if there are any folds in the capsule, I have noted that many times these fibrose more. And that is something which I have noted in some of these cases. Yeah, Dr. Rishi, please.
I think that's a good point, and it's a good question by Dr. Suresh. I think the two things that will probably determine what approach one would take would be individualized. So one would be the extent of the clock hours of the zonular dialysis. So if the zonule is missing in more than 6 hours, I would be hesitant to try and sort of try and restore the capsular bag. I'd rather just do a glued IOL and then hope for the best for the long term. The other thing would be the question of the progressive zonulopathy. And I think I agree with Rajesh that those with congenital subluxations, even those with myopias. I mean, I had a patient who was operated, I think, 10 or 12 years ago with the CTR, and his whole CTR IOL complex was lying on the retina with a very, very minor trauma, just a rub. And we had to then explant it and then naturally do a glued IOL. So this is, I think I agree. So going back, maybe in that patient with very high myopia with a subluxation, it probably would have been better to have done a scleral fixated implant in the first place.
One thing I noticed was very nicely, fixed by Gore-Tex that you used, Dr. Sonu. So you get it freely. This Gore-Tex sutures in Jaipur?
Gore-Tex is freely available with most of these periodic cardiothoracic surgeons. I think they routinely use this, and it's freely available. Just responding to Dr. Rishi's point, so I think that is where the role of preoperative evaluation actually comes into. So sometimes, when the clock hours are overlooked and you just do away by pushing in a CTR, at times, the lens might be just stable even with the CTR. But actually, where the lens was requiring maybe a 1-point or a 2-point fixation, and I'm pretty sure once you have a CTR and a 2-point fixation, even in the worst case scenarios, the lens, remains rock stable, even in the best of the cases. So I think preoperative proper assessment of, the degree of zonular lysis, and yes, rightly pointed out by Dr. Rajesh, whether it's a progressive or it's a stationary is a key to the success with these patients.
Any other comment from any of the panelists? Dr. Sharath, are you there? Dr. Sharath also had some important work. So,
I think Sonu has given a fantastic demonstration with the cortex.
Videos.
Yeah, wonderful.
Wonderful videos. Very tough case.
Absolute clear cut 1, 2, 3. He has shown all the slide. 3 clock hours, 6 clock hours, suspension.
Yeah.
What more can we expect?
Yeah.
My question generally, which I like to ask is, if you don't have any capsular bag, how many have you put anterior chamber IOL? And old patients who come to you after 20 years, you still have them. I just want to know, we have totally yeah, exactly, Rishi. I want an answer from you. Go ahead.
Oh yeah, lots of them. I'm a great fan of AC IOLs, especially the Kelman 4-point fixations. The only thing, there are a few tips. One is, of course, that one must remain as anterior as possible when you are actually implanting it. The lens will find its own place. Try and ensure that you have a round pupil at least when you finish. And always create a ledge. So where your incision, because these are not foldable lenses, you've got to go, 6 mm and you've got to put in sutures. So always create a posterior ledge when you do an AC IOL. Of course, the last thing is chamber must be deep. You must do a gonioscopy beforehand, and you must have a good endothelial cell count. Those are prerequisites for any AC IOL. They do fantastically well. And for years and years and years and years, I have patients I have followed up for 20 years, no significant cell loss. And very happy with the outcomes.
Iridectomy. Only thing I would add.
Yeah. PI, of course. Yeah.
Good, important functioning iridectomy.
Absolutely. Yeah.
I have one question. There are several of the modification of the IOLs which have come. I mean, it's not the glued IOL exactly like we have the one advocated by Dr. Nivian, where, it just has a flap kind of a thing and you just take it out, or you have by the care group, Dr. Parthrana advocates. So anybody has experience with those kind of IOLs, which are not actually 3-piece IOLs, but they are glued. They're not glued IOLs, but they're scleral fixated IOLs. And these are fixated in the pockets, which are made. And you don't have to actually use the 3-piece, but of course, you'll have to buy them, and you'll have to order them in that particular. So any experience, Dr. Sonu or Dr. Suresh, with those kind of IOLs?
I don't have any experience with any of these lenses, but yet we have seen all these people doing amazingly nice job when they've been showing their cases.
Yes, no experience with these IOLs.
Actually, various modifications have been, described. So people have their own ways of doing it. And there are some of the very nice techniques that have been demonstrated in some of these surgeries that we have conducted through AIOS. So I think there's some very good techniques that have been.
I think another thing that we've never talked about is the posterior segment problems that can occur many years after doing a glued IOL, or many years after, fixing the bag and putting the lens in the bag. So that is something, long-term results of what happens, especially the posterior segment problems, CME or any traction, or that is something which nobody is actually reported also, and that is something.
Actually, CME, regarding CME, I can definitely say, because there was one study we had done comparing sutured versus the intrascleral haptic fixated IOLs. So the intrascleral haptic fixated or the glued IOLs, they have a segment that is fixed. So they are more sturdy, and the pseudophacodonosis is less. With sutured IOL, one point is fixed. So same, I think, I've not done a study, but same, I think, for Yamane also many times, or something people have described, like, using the Prolene, etc., by fixing at one point, then the chance of pseudophacodonosis is high in those cases. Then cystoid macular edema, again, the risk is higher in those cases.
No, vis-a-vis the ones that you preserve the bag and then you put the lens in the bag with the Sioni ring or with the Sioni ring. So I think vis-a-vis that is something, would be worth looking at.
That's true.
And of course, the iris.
Once again, similar group of patients have to be taken in that study also. And because the indications become a little different, that, in less subluxation, people like to fix.
There are going to be too many variables to match.
The other other variable would be inflammation. And, the more the pseudophacodonosis, the more the likelihood of there being low-grade inflammation in these eyes over a longer period. So we've just got a flare meter. So we're going to be now looking at some of these inflammations and trying to see if we can get some real good data coming out of that.
And with the pseudophacodonosis, what happens that the traction is there on the macula as well because of the vitreous attachment. So I guess another variable, as you said, another variable is that if somebody has a total PVD, then in those cases, this will not matter much. I mean, any pseudophacodonosis will not cause traction on the macula and will not increase the CME. So again, that is another variable which has to be excluded and compared if we are comparing two groups like that. So
Rajesh, inevitably what you're saying is inject some air, create a PVD in these patients.
Not
primary.
Yeah,
not a bad idea. Seriously, I mean, I'm talking as a red
no. Actually, if you inject air with some attachment of the vitreous, and when the air moves, sometimes it can create giant tears in the retina. So that is one problem. So just by injecting air, sometimes it can have a very uncontrolled behavior, and it can create tears.
It can be induced even by just applying the suction ring of the when you're doing LASIK, just you put suction ring there, then also PVD has been induced. There was one study from RP Center only where, Dr. Pradeep Venkatesh has looked at induction of PVD following application of suction.
Actually, there was more PVD noted in those cases. But whether we can actually induce PVD in all the cases, it's very difficult to say, because for that you have to, give suction going close to the disc margin. So
I think maximum PVDs are induced after cataract surgery when you don't fill the chamber. When there is rapid inflation of the anterior chamber. I think maximum PVD is post-op 15 days, 1 week post-op, 15 days post-op. Patient suddenly starts complaining of your floaters suddenly, commonest complaint that we have post-op.
I guess Dr. Sonu has to go for his surgeries. So any other comment from any of the panelists? So I would like to have the concluding remarks from our president, Tyal sir.
I can only say one thing, all these difficult cases of subluxation, I've been managing these cases very effectively for so many years by giving all these surgery to Dr. Rajesh. And I have no complications of these cases. And he's done a wonderful job for all these patients. I think effectively, as we discussed, all these difficult cases, I think the experience is key here, because when you tackle the difficult situation, the experience has to be there with these cases. And seeing this, amount of presentation we are making through various societies, the videos available on the YouTube, that has made, learning and appreciating difficulties and the clues, tips given by experts. I'm pretty sure it is going to translate to all the young surgeons also. And these people who are now getting trained, they have a much, faster learning curve also. They effectively do better surgery than what we have been doing at that particular age. And the area we covered today, one was the newer way of looking into the cataract surgery, both surgery outcome wise, also the femtosecond laser assisted surgery, which should effectively translate into this subluxation group also. If we look into the type of subluxation, amount of subluxation, in fact, I could do a capsulotomy in all types of subluxation. In fact, there was a case where the lens was just hanging in the vitreous. There also I could do a capsulotomy effectively. And there was one case which I already published in IGO. The entire vitreous was in the antechamber. And there was always a concern that if you have a vitreous in the antechamber, your capsulotomy may not be appropriate. There also we could achieve a nice capsulotomy in a case of subluxation. But completion of surgery, then implantation, IOL, fixation will all depend on to the how effectively you could save the bag, or you could retain the amount of granules which are there to safeguard your bag composition subsequently. And as Namrata rightly pointed out, that long-term outcomes not only depend on the bag centration, the visual outcome and the complication related to that, both posterior segment, which may be the major, but some of these cases would have a silent blindness happening because of we are not looking into the glaucoma part, because especially post-traumatic subluxation, you can have an angle damage, glaucoma. Silently, you can see the optic nerve atrophy also. I've seen few cases of these cases losing vision because of undetected glaucoma in these patients. So rightly pointed out, and discussion was also directed to those areas of complications, which might take away the advantage of the surgical procedure we have done, like fibrosis, decentration, everything we talked about, and implantation of premium IOL in these cases where the bag is not going to remain centered is also important consideration, especially trifocal, multifocal lens in these cases. I remember one publication that Rajesh did with me was, giving a relaxing YAG laser capsulotomy in these cases of, where you have little smaller rexes, bound to be a small rexes in these cases. And if you do a timely relaxation of these, fibrous area of capsulotomy or a capsular rexes, that also prevents the phimosis and the traction happening in these cases also. But I think we had a very nice discussion today on a subject which is common to everybody.
If I can just add
please.
the name of that capsulotomy, it was posterior stamp capsulotomy.
Posterior stamp.
I remember
That's
doing
correct.
the paper with the posterior
That's
stamp capsulotomy.
I still do in many of my cases,
So actually, sir had done those surgeries and I had it in the paper.
You people have been a very good assistant to a mediocre person in terms of writing and publishing. Wonderful job you people have done.
Wonderful job done by your surgeries. We have learned from you only.
Thank you so much, sir.
Yes, sir.
Thank you, everybody.
Thanks a lot to all the speakers and all the panelists. And I thank you all. I thank the staff, Mr. Anil Kumar and Shivam, the IT person, Mr. Bageshwar, and IPCA for supporting this webinar. So thank you all once again, and a very good night to all.
Good night.
Thank you.
Thanks,
Thank you
everybody.
all the speakers and the panelists. Wonderful job today. And thank you,
So-
Rajesh, for organization.
Thank you.
Thank you.
Lovely webinar. Thanks, Rajesh and Namrata.
Thank you.
Nasreen, can we go offline?
Thanks, Steven.
Sure, sir.